Thanks, Marty. So exactly that, and let's see. Here's my disclosures. I think a picture, in this case, for TR is worth 1,000 words. As you can see, this prototype patient that illustrates the problem of TR as our patients experience them. Yeah, it's not just the leaking valve, it's a consequence of the peripheral edema, how that affects their skin, and so many of them that have friable skin, how it affects their liver and the degrees of hepatic dysfunction, coagulopathy, and so forth that comes with that, and then in turn, the kidneys as well. And I think tying all that together is the other part of the tricuspid valve, which is the right ventricle. And I think our understanding of the RV, in health even, let alone dysfunction, is so rudimentary. That is where we really need to put a lot of our efforts into understanding so that we can move this whole field forward. So many times I get patients referred as I've gone around trying to create referral lines for our tricuspid valve program, and it's clear what matters to us as we're trying to understand this disease process isn't the same as what matters to our referring cardiologists in terms of they want their patients to live longer and better. And for tricuspid valve disease, it's so complicated. I found this slide Bessler and company put together for the Europeans. And I think it really, we printed this out and put it up in our valve clinic too, because it helps us think through all the different components of tricuspid valve disease, be it functional or organic, and how we have to make sure, check the boxes, say, did we address this in the evaluation process, let alone treatment? But in terms of the question of this talk, so what should be the medical therapy standards? Definitely a high percentage of patients have concomitant arrhythmic disease. And so we don't have data saying, is rate control alone enough in AFib with severe TR? Or do we also have to think about rhythm control for those subset of patients? Certainly those that have concomitant left-sided ventricular disease, cardiomyopathy, and severe TR, before addressing the TR or concomitant with it, you have to address that left ventricle. Same thing with aortic and mitral valve disease. Our surgical colleagues have a little bit more runway behind them in this, that they have some guidelines to tell them when they should put a tricuspid ring on. As we approach that with transcatheter therapies, at a minimum, I would argue that we need to treat their aortic and mitral valve disease first, before then getting them into some of these trials on the tricuspid side. Pulmonary hypertension, in some ways, is a bit of a misnomer in tricuspid valve disease, because when the RV is shot, when the tricuspid valve is leaky, oftentimes they can't generate a high pressure into their pulmonary circuit. So we really should be talking instead about pulmonary vascular resistance evaluation and appropriate therapy of when it's elevated. And lastly is diuretics. Here's an example of a patient that just diuresis, aggressive diuresis alone made a big impact. Sometimes we see this, sometimes we don't. I really do think it's how recoverable is that right ventricle to say, does a patient improve like this type of thing? So these are my attempts to answer these questions. What are the medical standards that these tricuspid patients need to meet first? So thank you.
So Scott, when you enter a patient in a TR trial, we talk about medical therapy. Is there anything, you've talked about some of the specific things that you look at. When we deal with guideline-directed medical therapy for heart failure and reduced EF, we have drugs, we have drug classes, we have doses, we have time for response. We don't seem to be doing very much of that on the TR side.
No, it's literally only, are they on a diuretic? And despite that diuretic, are they symptomatic? And then we say they failed their medical therapy. Yes, I think if they have concomitant AFib, we really ought to treat that. Sure. If they have anything left-sided, we ought to treat that. But otherwise, medicines-wise, it's literally just diuretics. Even bringing them in the hospital and putting on milrinone, there's no data saying that's beneficial. Certainly there's some heart failure colleagues of ours that argue for it. But yeah, we're missing a lot there.
Do you push the diuretic to threshold from the standpoint of responsiveness?
So, or lack thereof. We certainly do push the diuretics. And then it a little bit becomes a balancing act, at least in my mind, in that discussion with the patients and their families of saying, all right, so how inconvenienced are you by having to go to the bathroom and urinate 10 times a day versus taking a risk of really all the device trials you've heard about, the devices are truly experimental. And there's not enough numbers of patients being done with them to speak terribly confidently about the safety profile. Unlike on the mitral side of things or aortic, we have a much better handle of that. So I believe we have to be a lot more circumspect and not let just patients get in the trial because they don't like taking a diuretic once a day.
Is there any value in I mean, after a device-based therapy, following diuretic use as a indication of benefit? Because we've seen some patients who are diuretic unresponsive, after you treat the TR, they become more diuretic responsive, and you can actually increase the diuretic dose more effectively.
Yeah, and one of the challenge that complicates the answer to your question is we've also seen some patients that we get an acute, really nice result in reduction in the TR, and then it seems like their right ventricle remodels somehow put strain on, I'm thinking of patients with our original tri-line experience, put strain on the repair, and they then start leaking, their tricuspid valve leaks, but in a different way. And so without having data really to guide me, just my gut intuition, I've been pushing the patients to, at the minimum, maintain the same diuretic doses for between 3 and 6 months afterwards, just giving time for everything to heal up before we challenge that. But you're absolutely right. I've also had a number of patients that come back and say they're now peeing like racehorses where before they weren't. So it's there's a lot going on here that I don't think we fully understand. I'm curious to other people's how they approach it. Paul or Becky, how do you approach the patient who you're going to intervene on their tricuspid valve in one of these clinical trials? Do you keep the diuretic doses the same afterwards, or do you let the patients come off it if they're feeling better?
So I do think that there's something to once a TR correction or a repair has happened, that there's a drop in the renal perfusion pressure, and it allows people to diurese even more briskly than before. And I think that it's quite amazing because it doesn't take that much. In other words, small changes in the renal venous hypertension can actually allow a much greater proportion in terms of diuresis, and I've been quite impressed with that. That being said, and we discussed this earlier, I do have concerns that we are hiding the impact of TR with the use of diuretics. In other words, you can have dynamic TR based on whatever etiologies there might be, but if you've got a mechanical reason for a leak, putting them on a diuretic and then saying that they're fine, I think is a bit, it doesn't serve the patient well. We wouldn't do that for mitral disease. You know, we certainly optimize the therapy, but you know, if you had a degenerative lesion, you wouldn't medicate them and say that they're not surgical now. And so what that trial of diuretic is for TR, I don't know, but I would love to see us understand that a little bit more.
What do you think about, are we measuring the right thing in terms of, one of the things that just occurred to me as you said is, why should we not be measuring renal vein indices in some way?
Yeah, so I think there are a whole host of things because when you think about it, you know, the TR, we think of end organ damage as being the RV, but it's so much more than that. And we know from CT data that the right atrium dilates before the RV does. And so we know that right atrial hypertension and the end organ's effect on the liver and kidneys is happening long before the RV starts to really dilate. And so I do think that when we look at the impact of our therapies, we have to assess those aspects, whether you directly measure renal vein hypertension, or Becky showed me this great paper earlier about liver stiffness. I mean, those are the types of things that, you know, whether it's, you can talk about that more, Becky, that or gamma GT or something that, or more surrogates for end organ damage, not just the right ventricle.
Yeah, I think we've struggled to try and find a marker for that, elevated right atrial pressure and, the narrow pulse pressure because the kidneys obviously work by perfusion pressure. And so we found exactly as you said that patients will, after a device with 1 grade reduction from torrential to massive, they just start responding to their diuretics a lot better. And many of the trials have, because it's very hard to monitor changes in medications during a trial, many of the trials have asked that the meds not be changed so that that's not another variable in determining the efficacy of the device. And I believe in that we should try and keep them on the same doses. The patients that have come back to have a repeat trial line, for instance, were ones that went off their diuretics. But the liver stiffness has been shown in pulmonary hypertension and heart failure literature to be an extraordinarily good marker for right atrial hypertension, for right atrial pressures. And I think it's a very easy thing to measure, and Paul and I are thinking that we will just maybe add it to one of the imaging sub-studies.
It's not a simple palpation, is it?
No.
So how do you measure it?
It's a specific echo machine that measures. I think it's just the flow within the hepatic veins, but and measures the sizes of the and the pulse pressure of that. I have to reread all that stuff because it's not stuff that we do, And as far as renal perfusion, we've attempted to get renal artery Doppler through the back. It's pretty darn hard, so I just don't know non-invasively how to.
Yeah, well, maybe it is an invasive thing. We do right heart caths relatively frequently, but I know our interventional radiology colleagues oftentimes are asked to get portal hypertension measurements by simply taking a balloon wedge catheter down there, and maybe we ought to find ways to look at that to better understand, as you were saying, liver stiffness.
Yeah, this is non-invasive, so it's could be done at the bedside. I don't know. I think we ought to think about that because I just don't think gamma GTP is going to do it for us. It's not going to be a good marker.
Yeah.
So I think we've concluded that unlike left heart failure, there really is no guideline-directed standard therapy for right heart failure. And our heart failure colleagues pretty much agree. Everybody talks about diuretics, but the use is quite variable in terms of dose and in terms of intensity. I think there is clear evidence, as Paul said, that you don't need much of a change in the severity of the TR to change renal perfusion and to make some patients, and it's hard to predict exactly which ones, dramatically more responsive to the same dose diuretic. We've seen that, and that's pretty impressive. But it's a little bit hard to predict which patients are going to respond that way. And in terms of rate control with AF, that's an obvious area that people focus on appropriately. And I think, of course, understanding pulmonary hypertension in this population is important. But the point we're making is that, as we talk about doing clinical trials and as we look at therapy goals, we don't have much from the standpoint of medical therapy on the left side, we've got 5 drug classes and drug groups that are literally class 1 indications. In terms of improving mortality in heart failure and reduced AF, we have essentially nothing on the right side.
Becky and I were on a lot of the calls for the Triluminate EFS, and the question was always asked, is this patient optimized on medical therapy? And there was just a lot of hemming and hawing. But there were also some people who were pretty dogmatic about, well, they're only on 10 of Lasix. You got to push that, but push it to what? And that's where we struggled. We don't know exactly what that maximal dose is. We have good ideas for left-sided disease in terms of what doses the ACEs and beta blockers should be, but for diuretics, I don't think we really have a clue. So.
It's why in the guidelines, a diuretic is still like a class 2B. It couldn't even get to an A. So.
Well, do you think then, Becky or Paul, is there any role for then having an invasive metric, like what is the right atrial pressure? And certainly if a right atrial pressure is in the mid to upper 20s, most people would argue they're not on enough diuretics.
Yeah. No, I do. And so as part of Triluminate Pivotal, we are requiring a right heart cath in all of the patients. And it'll be actually, we feel it's clinically indicated. And so that'll give us some information about what should be done. But I do think that is helpful, so.
Okay, I think we're going to move on. Our next speaker, Gilbert Tang, unfortunately was caught in a travel conundrum and is unable to make it. He was going to provide some perspectives from a surgeon on the role of transcatheter therapy, although we've had several surgeons speak earlier in the day, and some of the perspectives are in fact quite interesting. And maybe we'll touch on that as we go further and talk a little bit more about therapy goals.